some of the basics of tall stature and its causes and its differential diagnosis. And also, we're going to discuss the Beckwith-Wiedemann syndrome. So, actually, in what happens in Wiedemann syndrome, it's actually overgrowth syndrome, and it occurs with an incidence of 1 in 10,000, equal in males and females, and it is caused by genetic or epigenetic abnormalities in the 11p15 chromosomal region, with most cases being the result of epigenetic abnormalities. So what happens is there is macroglossia, and there is omphalocele, and there is lateralized overgrowth, which is called hemihypertrophy, and there is bilateral Willem's tumor and hyperinsulinism, and pathologic findings like adrenal cytomegalomy, pancreatic adenomatosis, and mesenchymal dysplasia. So there are many features in Beckwith-Wiedemann, like there is macroglossia, and there is omphalocele, and there is hemihypertrophy. And also there is other pathological abnormality, adrenal cytomegalomy, adenomatosis, mesenchymal. So there are other features also like macrosomia, and there's midglobular capillary malformation, nevus flammeus, and there could be also earlobe creases and pits, and umbilical hernia or diastasis recti, and hepatomegaly, nephromegaly, and unilateral Willem's tumor. So the hyperinsulinism is basically because of the hyperplasia of the beta cells of the pancreas. And the child can be exposed to embryonal tumors and Willem's tumor and hepatoblastoma, neuroblastoma, and also to adrenocortical carcinoma. Okay, so the management focuses on omphalocele airway issues like macroglossia and neonatal hyperinsulinism, hypoglycemia, Legland discrepancy, and like you will manage symptomatic, So what happens in a Beckwith-Wiedemann syndrome? And let's summarize it. There is macroglossia, and there is there's macroglossia, there is omphalocele, and there is macrosomia. There would be hypoglycemia because of the hyperinsulinism. There could be nephromegaly, and there could be hepatomegaly. There could be Willem's tumor, and there could be midglobular capillary malformations, earlobe creases and pits, umbilical hernia, transient hypoglycemia, hepatoblastoma. So these were the pictures of actually Beckwith-Wiedemann. Now let's come to the differential diagnosis of tall stature, which is also our main topic actually. Is you will ask about the history from prenatally, like there could be maternal diabetes mellitus, And there could be Sotos syndrome, Weaver syndrome, Beckwith-Wiedemann syndrome, and Marshall-Smith syndrome. So there could be fetal overgrowth. And after fetal overgrowth, there could be other causes like postnatal overgrowth leading to childhood or adult stature, like non-endocrine causes, which includes familial tall stature because the parents could be tall. There could be exogenous obesity. There could be Sotos syndrome. There could be Weaver syndrome, Marfan syndrome, homocystinuria, and Beckwith-Wiedemann-Klinefelter. And all these syndromes cause tall stature. Which syndromes? Klinefelter, homocystinuria, Marfan syndrome, Weaver syndrome, Sotos syndrome, and it could also be familial. But there are also certain endocrine causes like excess growth hormone secretion or because of any pituitary adenoma or X-linked acrogigantism. Macunal bright can cause tall stature and peripheral precocious puberty. And there could be aromatase deficiency and estrogen receptor defects. Sometimes precocious pubertyism is also one of the cause. So these were the causes of tall stature. Here I would like to discuss some of the overgrowth syndromes. They are Beckwith-Wiedemann. I told already that there could be hypoglycemia. There could be macroglossia, ear pits increases. There could be omphalocele. There could be nephromegaly, hepatomegaly, organomegaly. High risk of embryonal tumors and hemihypertrophy. And the other ones, which is of significance, is Sotos syndrome, and it causes excessive growth in first 4 years. There could be dolichocephaly. There are different skulls, shapes, abnormal shapes. Dolichocephaly is when it is elongated along the x-axis. The head is elongated along the x-axis. When it is vertically elongated, it's called acrocephaly. And the other one is plagiocephaly. So, in Sotos, there is dolichocephaly, there is macrocrania, there is typical facies, and supernumerary nipples, cardiac, and skeletal defects. Now, let's discuss about the approach of a tall stature. Like, how would you examine a case of a tall stature? So that's also pretty important. And that can be like the general look. What will you see in a general look of a tall stature is before following the wiper principles, wash your hands. Introduction, position the patient, expose the patient, and right side to approach. What do you do is you do the general look. And in general look, you look for the body habitus, like to check whether it is morphonide, eunuchide, and you will see for the tenor staging, like delayed or advanced. Then you will look for any skeletal anomalies. Skeletal anomalies like asymmetry, as in Beckwith-Wiedemann syndrome, as in neurofibromatosis type 1, meconial bright, and Proteus. Then you will see for any pectus excavatum or carinatum, and you will look for any scoliosis like Marfan, Sotos, homocystinuria, Mantubi, NF1. So the next one is posture. Like as a hemiplegic posture happens in homocystinuria. So, and the other one is the skin. You will look for skin like the capillae spots in mecunal bright, in neurofibromatosis type 1, and Proteus. And you will look for subcutaneous tumors, e.g. lipomata, hemangiomata, and hyperpigmented areas, and acne. So what will you look generally in a patient with tall stature is that body habitus, tenor staging, skin, the skeleton, and the posture. And the step two is the measurements. You know what? You will look for, you will do the standing height, then you will do the upper segment height, which is calculated as the sitting height, and then you will calculate the lower segment height, which is calculated by subtracting the upper segment height from the total height. So at birth, the upper segment lower segment ratio is 1.7, remember, and it's at 3 years it's 1.3, and at 8 years it is 1, and at 18 years it's 0.9. So then you will look for the arm span, arm span from 0 to 7 years it is minus 3 centimeter, and from 8 to 12 years it is 0 centimeter, and from 14 years, at 14 years for girls it is plus 1 centimeter, and at 14 years for boys it is plus 4 centimeter. Then you will look for the head circumference and weight. So these are total the measurements. The next is the maneuvers. It is step 3. The maneuvers are, first maneuver is hands and feet together. The second one is bend over and touch toes. The third one is beat and score for hypermobility. And the fourth one is arachnodactyly tests. The fifth one is arms out straight. And number 4, you will do systemic relevant examination. You will check the gait, you will look for upper limbs, for head, face, eyes, nose, mouth, and chin. So these are the steps. And in the last offer for vitals for child's progressive percentile charts, parents' heights, visual field examination, endoscopy, and child's X-ray. And in the last, describe it.